visible?
Yes, sir. You're audible and visible.
Hemodynamics of PPHN. That's the screen.
Yeah, Dr.
Yeah.
Pradeep.
Thank you. So now from pathophysiology, now you understood that you need to have assessment of pulmonary pressure, assessment of shunt, assessment of right side functions, and assessment of left side function. So today I will try to cover simple aspect of pulmonary pressure. Naturally, in future we'll cover also the right side functions and left side functions as the time part comes out. But the methods of assessment of the pulmonary pressures are actual measurements by TR jet, pulmonary regurgitation jet, and by PDA or PF4 shunts. Then we have the crude markers. The crude markers that this could be moderate or this could be severe. We don't have numbers. And these markers have correlated previously with the cath lab markers. Those are markers called as pulmonary artery acceleration time, pulmonary artery acceleration time versus RVET ratio, septal position, LV shape, and LV eccentricity index. These are the markers we will discuss in next 20-25 minutes. So that is the markers for measurement of pulmonary pressure. From this marker, you can consider that we are dealing with mild, moderate, or severe pulmonary hypertension. So I think you all do this echo. The best view to do the TR jet, the first marker for assessment of the pulmonary pressure is a tricuspid regurgitation, and the best view is apical four chamber and a plaques RV inflow view. These are the two views where you see the TR jet as a blue color, and after your grayscale, put a color. After color, put a continuous wave Doppler. So once you put a continuous wave Doppler, you get a velocity. Measure that velocity gradient. So this is the peak of the velocity. In this case, the peak of the velocity is 3.67 meters per second. Apply the Bernoulli's equation. Whenever you want to calculate any gradient, TR jet, MR jet, PR jet, AR jet, VSD jet, ASD jet, all these jet or pulmonary stenosis, aortic stenosis, everywhere, you will have to put continuous wave Doppler, measure the velocity of that jet, and apply the Bernoulli's equation. Bernoulli's equation, as you know, 4 into V square. And in this case, if you see now, 4 V, this is 1, this is V. The constant pressures in the RA by catheterization lab is between 5 to 8. For calculation purposes, we take a lower value, that is 5. That is RA systolic pressure. So I got this value of RV systolic pressure. This RA systolic pressure that combines is a 59. So my pulmonary artery systolic pressure in this case is 59. That's how we calculate by TR jet pulmonary pressure. That's only one method. A lot of people do TR jet, pulmonary hypertension, start treatment. No, your echo has 20 parameters, and that's where people are failing. That they do one parameter and finish the echo, and that is what is the commonest mistake we do. Before doing these parameters, you have to label a normal echocardiography, structurally normal heart. And the TR jet is the commonest problem seen in CCHD. You have TGA, you have tricuspid atresia, not tricuspid atresia, pulmonary atresia, severe pulmonary stenosis, you have DORV, you have left hypoglossal heart, you have Epstein's anomaly. All the conditions will have TR jet. Hence, friends, remember, TR jet, once you see, please rule out structural heart disease. This echo you are doing on structurally normal heart. You are not doing on the babies of CCHD. That's the second important message I want to give here. So this TRZ you have measured. That's one example. I told you the steps: apical 4-chamber, color, TRZ, apply CW, measure the velocity, apply 4V square, 4V square plus 5, that is your pressure. So this is the another example: 4-chamber, color, and you saw the TRZ, measure, in this case velocity is 3.93, 4 into velocity square, 62 plus 5, 67. These are the pressures for this baby. So that is a one method of TRZ by one view, that is apical 4-chamber view. But I would say that always try to see the TRZ by RV inflow view, Flax view, then RV inflow, and in that RV inflow, again velocity, again TRZ velocity, velocity gradient. Once you get velocity, apply 4V square, that is the pressure gradient. Pressure gradient plus 5, you get the systolic pressure. So TRZ should be measured by two methods: apical 4-chamber method and Flax RV inflow method. That is about TRZ. You also have 70%, 60 to 70% babies only have TRZ, not all the babies. That means you are going to miss 30 to 40% of the babies if you only rely on TRZ. Hence, I am talking all these methods to you. Especially the preterm BPD pulmonary hypertension, you will not see TRZ, you will not see PRZ, you will not see the PDE also. So there are other methods. So this PRZ method, again, this is the short axis view. In the short axis view, put up CW, you get this velocity. If you measure the velocity of the peak, then you get systolic. You measure the lower velocity, you get diastolic. But preferably just measure this one. Again, same equation. Velocity, 4V square, and velocity should be in the meters per second. That is also important. A lot of people make a mistake that they don't measure in the meters per second and they end up with the wrong diagnosis, the wrong measurements. So I told you 4V square, that V should be in the meters per second. That is what I told. This is another example of pulmonary regurgitation. That's again, put a velocity, calculate another example of peak velocity, and this peak velocity again apply 4V square. So you can have TRZ, you can have PRZ. The PRZ can be seen in the short axis view or Flax RV outflow view. These are the two views where you can see the TRZ. So I told you TRZ by two views. I told PRZ by two views. That's the four things I told you. Next method is shunt assessment. What is a shunt assessment? The shunt assessment is a PFO, and PFO should be assessed by subcostal long axis view, subcostal long axis atrial view, and put a Doppler again there, which is a pulse wave Doppler, and just see whether you are dealing with PFO bidirectional or right to left. If it is a bidirectional or right to left, that's a patient of pulmonary hypertension. Similarly, you need to assess the PDA. Now, as you know, the three-leg view, that is a ductal view. Put a Doppler at the pulmonary end of the duct. Once you put a Doppler, normally your pulmonary pressures are below and your systemic pressures are high. Hence, you get left to right shunt. So in the transitional period, in the first 12-24 hours, if you put a Doppler, you will have left to right PDA because your aortic pressures are higher than your systemic pressure. Sorry, than your pulmonary pressures. And that's the way you get left to right. When you see such left to right, that is a positive deflection. That's a duct. What you say? Left to right duct means your systolic pressures are always, or the systemic pressures are always higher than the pulmonary pressure. That means you are not dealing with the case of pulmonary hypertension. That's your safe. But when you see the bidirectional PDA, or that's a bidirectional PDA. This is left to right, this is right to left. Or you see classic right to left, that is a negative deflection. That is pulmonary pressures are high. bidirectional or right to left. That means your pulmonary pressures are higher than your systemic pressure. In the bidirectional PDA, the right to left component should be more than 30%. Those people who are doing echo, they knows what I'm talking. So this is one method. In this method, you see the duct, put a Doppler, which is a pulse wave, and you get this right to left. In this right to left, measure the velocity of this right to left. When you measure the velocity of the right to left, again apply Bernoulli's equation, 4 into v square. You got pressure gradient. Now, you know the systolic blood pressure by invasive or non-invasive method. By cup method or by Artline method. You have systolic blood pressure. So you know that suppose this baby's systolic blood pressure is 50. And with this 50, I have right to left also. That means the systolic is 50 and the pulmonary is above that. What is above that? You add this velocity, you add these 4v square pressures into that 50. That is your pulmonary pressure. So in this method also you get numbers. TRZ you got number, PRZ you got number, PDA you got number. How to number? I told you bidirectional or right to left. Measure the 4v square of right to left component. And once you have that, that's what I'm telling you, that once you have that, this is example of right to left. This is the velocity of right to left, 2.7. Velocity 4 square, that is your pressure around 30. And I know the systolic pressure by measurement of cuff, 40 plus 30, 70 pressure I got in this baby. That is what I'm talking here. So what we are talking here? We are talking here as a suprasystemic pressure. I know the systemic and the suprasystemic, these are right to left. So friends, when you're talking bidirectional, this component should be more than 30%. Once this component is more than 30%, then do the right to left component measurements. So this is the chart which is very important. When you see only left to right PDA, that means your systemic pressures are above than your pulmonary. When you are talking about right to left, your pulmonary pressures are above than this one. So what you do? The systolic blood pressure plus pressure gradient of right to left PDA. That is what we do measure. So these are the numbers you get. These are the methods you get numbers. In cases of bidirectional also, systolic blood pressure by invasive, non-invasive, and you add pressure gradient of right to left PDA. That's what I told you. So that's a method of shunt, and from shunt you calculate the pulmonary pressure. Same method you apply for PFO, same method you apply for VSD also. So any shunts which are bidirectional, which are right to left, by this method you can calculate pulmonary pressure. The normal values in the newborn, less than 35, 35 to 45 is mild pulmonary hypertension, 45 to 60 is moderate, more than 60 is severe pulmonary hypertension. After 3 months, number is 25. Because as you know, in the transitional circulation, pulmonary pressures are still high. The next methods of measurement of pulmonary pressures, these are the methods which you can actually, you cannot measure the numbers, but you can say this could be moderate, this could be severe pulmonary hypertension. So this method is always present in all babies, which is called as pulmonary acceleration time. Normally, acceleration is slow and deceleration is also slow, and it produces laminar flow of MPA. So this is the laminar flow. It is produced. Acceleration is slow and deceleration is also slow. This is called as parabolic or laminar flow of MPA through the short axis view. So that is what is normal phenomenon. But in cases of this is the normal phenomenon of laminar flow. But in cases of the PPHN, what happens? This is the normal phenomenon. This is what I'm talking about, normal acceleration and normal deceleration. But what happens in PPHN? this becomes triangle. So you can see the laminar becomes triangle. There is a sharp rise in acceleration, or it becomes W. So when we say it is sharp, it is called as moderate pulmonary hypertension. When we say W, it is called as severe pulmonary hypertension. So dear friends, remember these statements that by this method, you can able to say that this could be moderate, this could be severe pulmonary hypertension. That's called as PAT, or time to peak velocity. So PAT means pulmonary artery acceleration time. TPV means time to peak velocity. That is one method. So this is example of normal. This is example of triangle, moderate pulmonary hypertension. This is example of W pattern, which is what we are talking as severe pulmonary hypertension. That's again W pattern, severe pulmonary hypertension. When your PAT is less than 90, it is moderate pulmonary hypertension. When the PAT is less than 40, that's what we calculate the time. That is what we say is severe pulmonary hypertension. So the normal values are more than 100, less than 90 to 50 is moderate, less than 40 millisecond is a severe pulmonary hypertension. The next method is PAT and ejection time ratio. So you saw the PAT, now you have a PAT number, measure the RVET, that is ejection time, and find out the ratio. Same, naturally, again same short axis view, take a laminar flow, measure this peak, that's a peak from this end to this end peak, that is a PAT or TPV, and measure the RVET and that ratio. If the ratio is less than 0.3 and especially less than 0.2, you are in big trouble. So PAT RVET ratio, that is what I'm talking here. This is the TPV. In this case is 44 milliseconds, and RVET, that's RVET. And if you see, this is ratio is 0.2. TPV RVET ratio is 0.2. That means this baby has, I told you 0.3 to 0.2 moderate, less than 0.2 is a severe pulmonary hypertension. That's again crude method. It's not accurate numbers. So I told you the PAT or TPV. The second method is PAT versus RVET ratio. That's the second method. The third method is a septal position. And this septal position, you need to see into the short axis papillary muscle view at the end of the systole. Normally you see nice normal curvature. This is the normal curvature of the septum. In moderate pulmonary hypertension, this septum becomes flat. In severe pulmonary hypertension, this septum becomes bowing into the LV. Because this septum turns out this way, that's one method. You can say this is moderate pulmonary hypertension, this is severe pulmonary hypertension. You end up with the shape of the LV changes. That's another method. That is a shape, that is the first shape of the the position of the septum and shape of the LV. Here you see the shape of the LV is O-shaped. When the septum becomes flat, it becomes D-shaped. When the septum becomes bowing, it becomes crescent-shaped as a moon-shaped. Moderate pulmonary hypertension, severe pulmonary hypertension. That's again crude method, very important method. Example of O-shaped, example of D-shaped, example of crescent-shaped, some of the pictures, example of again O-shaped, example of D-shaped. These are the examples. When we say O-shaped, naturally, systemic pressures are more than the pulmonary pressure. When we say D-shaped, the systemic pressures are above, so pulmonary pressures are above than systemic, more than 50%. Crescent shaped, more than 100%. You are in bad PPHN. So I talked about TR jet and PR jet. I talked about PD and PFO. I did talk about TPV, TPV RVT, septum, LV position, LV shape. These are the various methods I talked. One more method is research method, but you should just know because you all are doing DNV neonatology or DM neonatology. So, which is again same view of a papillary muscle view, which is called as LV eccentricity index. That means measurement from parallel to this septum. That's one measurement. And the perpendicular measurement is the second measurement. Ratio of these two Normal is less than 1.2. Normal is less than 1.2. In cases of pulmonary hypertension, this ratio worsens. Another ratio, you need to see the RV versus LV. In this view, it is less than 1, as you know. But again, which deteriorates. So what we are talking here, see this example. This example now, this ratio is 1.27, which started worsening. This ratio is 1.5, which is worsened. This ratio is 1.9, that's a crescent shaped. This is a flat, that is a D shaped. This is a crescent shaped. This is 1.97. This is the normal. This is the normal 1.03. Here you see the RV by LV. This RV by LV is less, it's more than, basically more than 1. So that's a problem. So these are the examples what I showed you. These are LV eccentricity index and RV LV ratio. So I told you a lot of things. It's not only TRJ. Friends, a lot of people just, oh, TRJ, pulmonary pressure, this, start this. No, do everything. TRJ, PRJ, PFO, PDA, TPV, TPVR, ET ratio, septum, LV shape, LV eccentricity, and RV LV ratio. Very important. That's again RV LV ratio. These are important. Naturally, on the visual thing, you will see your RA RV dilated. That is the first impression. In PDA, you will see LA LV dilatation. Here you will see RA RV dilatation. That is very important when we discuss about these parameters. I will not go the measurements of RA RV. That's not the part of the